Society. Today, we're so pleased to have Dr. Jawa for the second time. Dr. Jawa is a consultant of nuclear medicine in Sultan Qaboos University Hospital and with the European Board of Nuclear Medicine. Welcome, Dr. Jawa, and this is a very nice day having you with us today.
It is my pleasure. Thank you very much, and thanks for this huge introduction.
Okay, I'll let you take it from here. Go ahead, sir.
Okay. Good evening to you all, and thank you for once again giving me the opportunity to discuss with you this afternoon. And I am pleased to be here again today. Today, I'm going to be talking to you on thyroid and parathyroid scintigraphy. And the reason why I chose those two organs because of their close proximity, their function which looks similar, and their disease processes which interplay together. And of course, in terms of imaging in nuclear medicine, the imaging modality are almost the same. So for better understanding, I lumped the two together. So this will be discussed in nuclear medicine on the endocrine, nuclear medicine endocrinology, but then endocrinology in nuclear medicine consists of thyroid, parathyroid, and mainly adrenal. So today we will just be discussing thyroid and parathyroid again because of the reasons I mentioned earlier. So what is important for us to note is that thyroid scintigraphy in nuclear medicine simply portrays physiology. So all we are imaging in terms of thyroid scintigraphy in nuclear medicine is that we are looking at the function of the thyroid. And we know from our elementary physiology that the main function of the thyroid is to metabolize iodine and production of thyroid hormone. So the main function of the thyroid gland is to produce thyroid hormone, and the images that we were going to be discussing in nuclear medicine just portray that physiology. And mainly this involves the intravenous injection of a suitable radiopharmaceutical, which I will discuss with you in the next slides. So this is what we do. In radiology, this is what you do. In radiology, you look at anatomy and morphology. You know that the thyroid is located in front of the neck. It has two lobes, the right and the left, joined together by the isthmic lobe. And occasionally you can see the pyramidal lobe and the vascular and other smaller structures within. So this is mainly what you do in diagnostic radiology. And this is what you see in your ultrasound, in CT, in MRI. But in the other hand, in nuclear medicine technology, what we are doing is that we are going beyond looking at structure. We are looking at the function of the follicular cells. And remember, the unit function of the thyroid gland is the follicular cell. And everything about the metabolism of iodine happens within the functional follicular cell. So for example, if this is the thyroid, I took out one of the follicular cell and enlarged it. And this is mainly what happens. The main function of the thyroid is that it metabolizes iodine. So iodide in the plasma is trapped into the follicular cell by the trapping sodium iodide trapping mechanism. And through that process, there is organification. It goes a complex system of organification. There is coupling, and then there is formation of, eventually there is formation of two thyroid hormones, the T3 and the T4, which are stored within the thyroid follicles and then occasionally released into the plasma as the need requires. So from plasma, you have iodide, it is trapped into the follicular cells. There is organification, there is coupling, there is storage, and eventually there is release. So this mechanism of physiology is indeed what we image in nuclear medicine in order to detect for pathology or identify disease processes. So imaging thyroid in nuclear medicine uses two types of radiopharmaceuticals. We use technetium-99m. And if you remember in our last presentation, we mentioned that technetium is the workhorse of nuclear medicine radiopharmaceutical. Technetium is produced by the molybdenum generator. Technetium specifically, the M has a short half-life of 6 hours. It has a gamma energy of about 140 keV that is suitable for imaging with our gamma camera. So the technetium is handled exactly the way the thyroid handles iodine. The only difference with technetium is that it is trapped by the thyroid follicle. It undergoes all the processes within the follicular cell, but it doesn't return it. Instead, it is excreted. It doesn't get into the metabolic process. So with that, we can look at the trapping function. We can look at the organification function of the thyroid. But more importantly, what we are looking at is the function of the functional thyroid cells. And of course, we can also calculate percentage uptake, which I'll discuss with you the importance of percentage uptake of the thyroid in my next slide. So when we are dealing with technetium-99m as a radiopharmaceutical for imaging the thyroid disease, majority of the disease process that we image are benign thyroid diseases, which I will show you later. And the images usually are acquired from the head to the upper chest. So benign thyroid disease, upper and from the head to the chest. This is what we do for technetium. The second radiopharmaceutical is iodine 123 or iodine 131. These are similar exactly to iodine. The only difference is that they are radioactive. Iodine 131 has the good property that you can use it both for imaging and for therapy. The reason why we don't use this iodine routinely for imaging rather than using technetium is that it has a higher energy. The photon that is released from those iodine are not very suitable. So the image quality is not as good as what you have in technetium. And they have a long half-life. For instance, iodine 131 has a long half-life of 8 days. That means that you will be exposing the patient to unnecessary radiation when you can use a substance that has a half-life of 6 hours and get the same information. But the advantage of iodine 131 is that it also undergoes the same process of metabolism. But in the end, it is incorporated into the thyroid hormone, so it is metabolized. It is not excreted like you have excretion of parathyroid. And the advantage of that is that we can look into detail of thyroid membrane function. And this is more important when we are imaging malignant thyroid diseases. And in this case, because we are imaging for malignancy, the images are whole body. So take-home point from this slide is that the two radiopharmaceuticals that I use for imaging the thyroid, one is mainly for imaging benign disease, and the second one, which is iodine 131, is used for imaging of the diseases that are mainly malignant disease conditions. Now, there are other radiopharmaceuticals that are also available that are used for imaging thyroid pathologies. I wouldn't go into details of them, but take note of technetium-99m systemivi, which localizes in mitochondria. I will tell you some of the advantages of that. Sometimes we use FDG, PET-CT, and then there is indium 121 for somatostatin receptor analog. So this is just academically for you to know that aside from the technetium-99m and the iodine 123 or iodine 131, there are other radiopharmaceuticals that can also be used to image the thyroid or thyroid pathology. Now, again, like we showed in the previous scan, what we do is if we are imaging benign disease with technetium-99m, we inject our patient, the radiopharmaceutical get access into the intravascular compartment. After about 10 to 15 minutes, it is localized within the thyroid, and energy, the gamma rays is released from the thyroid, which is detected by our scintillator camera, our gamma camera, and then you have an image. So this is what we do. So the images, like I said, is usually from the head to the upper chest region. This is using technetium-99m. But if we are using iodine 131, which we use for imaging thyroid malignancies, we do not inject. The patient instead we administer it orally. It is taken by mouth. It is a capsule. So it is ingested by the patient. And because it is ingested by the patient, it takes some time to metabolize and for us to do imaging. So depending on whether you use 123 iodine or iodine 131, and depending on the disease process that you are looking for and the dose that you inject, your imaging can be after 48 hours, 72 hours, or even longer. So, and in this circumstance, like I tell you, because we are imaging for malignancy, we image the whole body. You can see the patient whole body and from head to almost foot in anterior and posterior projection. So this slide just demonstrates to you the image acquisition of thyroid scintigraphy, whether we're looking for benign thyroid disease using technetium, or we are looking for malignant thyroid disease, we're using iodine 131 or iodine 123, depending on what you're using. Now, this is how we do it. If we do for technetium-99m, when we inject the patient, immediately after injection, it takes about 10 to 15 minutes to get the parathyroid or the technetium into the thyroid gland, and the peak of activity is usually at 20 minutes. So at 20 minutes, we image using sometimes the pinhole camera, the pinhole collimator. The reason for doing pinhole is to give you magnification, because if you use the normal collimator, you will have an image that will probably not give you a clear anatomical detail. But we can also use a pinhole, because pinhole causes magnification. So you can magnify the thyroid and look at the thyroid tissue itself and be able to assess the presence or absence of disease condition. So, but eventually in 20 minutes, this is what we do. But also of important is, apart from imaging the patient, one of the beauty about thyroid scintigraphy is that we can do quantification. And quantification means that we can give you the exact amount of dose. We can see how much of the injected dose has gone into the thyroid. And I'll tell you why this is important in subsequent slides. So what are the indications for thyroid scintigraphy? First, it is important that each time you are doing a thyroid scintigraphy, the thyroid scintigraphy is extremely, like in all other tests or all other investigation in nuclear medicine, they're extremely sensitive, but their specificity is low. And therefore and this is also true for thyroid disease or usually thyroid scintigraphy. So it is always important that whenever you are interpreting your thyroid scintigraphy, you interpret it in light of the clinical presentation of the patient, the serum thyroid function test of the patient, and ultrasound scan. And I would like to emphasize at this point that thyroid ultrasound is the first modality of choice for imaging patients with suspected thyroid disease, because ultrasound is accessible. It uses a non-ionizing radiation. You can repeat it as much as possible. So oftentimes our patients, before they come for a thyroid scintigraphy, would have had an ultrasound, and definitely most of them would have some form of thyroid function test. So the combination of your clinical information, your serum thyroid function test, and thyroid ultrasound helps you in increasing the specificity of your thyroid scintigraphy. So the clinical indication, like I said, there are two most important indications: benign disease and malignant disease. Now, the most common indication for a thyroid scan is in patients with hyperthyroidism. And we know patients with hyperthyroidism presents with increase in thyroid hormone. Their T3, T4 level is high, and there's suppression of TSH. And this patient have clinical symptoms of hypermetabolism, i.e. they have increased heart rate, they have increase in metabolism, they have a diarrhea, and they eat voraciously. Now, hyperthyroidism can be caused by several diseases, including Graves' disease, Pulmon's disease, toxic nodular, and of course, thyroiditis. And one of the importance of thyroid scintigraphy is to be able to differentiate the various causes of hyperthyroidism, because these treatments are different. But more importantly, for thyroid scintigraphy and in our day-to-day clinical practice, one of the most important clinical indications for thyroid scintigraphy is to distinguish the different form of autoimmune thyroiditis, autoimmune thyroid disease from particularly thyroiditis that is caused by either subacute thyroiditis or Hashimoto's disease. The second is to help in evaluating patients with thyroid nodule. But more importantly, or like we said, ultrasound is the main tool of investigation in this circumstance. But one of the times where a patient presents with a thyroid nodule with a low TSH is a clear indication to do a thyroid scintigraphy. And I will show you subsequently in my images what I mean. Another indication that we can get oftentimes is when you review your CT or your X-ray, you usually sometimes will find an incidental finding of a retrosternal mass. And we all know that differential of a retrosternal mass is a long list of differential, but one of the differentials is a goiter or a thyroid tissue. So if you want to know indeed if this is a thyroid tissue, we can send the patient sometimes to nuclear medicine and we can inject and if it is a thyroid tissue, it usually will take up some form of iodine or pateknate. We also use thyroid scintigraphy in addition to the ultrasound, like I mentioned, to evaluate patients with congenital abnormalities, such as thyroid agenesis, sublingual thyroid. Now, in terms of evaluation for malignancy, thyroid imaging with iodine 131 whole body plays a very significant role in monitoring patients with differentiated thyroid cancers, where we look at them post-ablation after they must have had iodine ablation, and is an important tool in following up patients for evidence of reoccurrence or metastasis in the future. So two main important indications: benign thyroid disease, essentially using technetium 99M, like I mentioned earlier, and malignant thyroid disease using iodine 131 or iodine 123, depending on what you're looking for. Now, this is a normal thyroid scan. So if you look at the normal thyroid scan on your left-hand side, this is the pinhole image. So initially what we do at the first image is we image from head to the upper chest. And the reason for doing that is to include the whole of the thyroid and its neighbor. Neighbors include the submandibular gland, the parotid gland, the submandibular, and you can see uptake within the mouth. And more important is that you can see the thyroid. But if you look at it, this is using the parallel hole collimator. So this gives you the entire picture of the head and the upper chest region, but it doesn't give you detail of the thyroid parenchyma itself or the thyroid follicular cells. So in order to do that, you can use a pinhole to magnify without causing this image distortion. So this is the magnified image of the thyroid scan. Again, remember, what we are imaging is the thyroid follicular cells. We are not looking at anatomy. We are not looking at blood vessels. We are looking at functioning thyroid cells. So any area that shows uptake means that that area has functioning thyroid cell. If that area does not have an uptake, or there's absence thyroid follicle, then it will appear as absence uptake. And no wonder why we use two terms, very important terminologies to describe abnormalities in thyroid disease, which I'll show you in subsequent slides, is the hot and the cold nodule. Hot area means there is an increased uptake. So increased uptake means that that area is rich and there is significant increase in thyroid follicle. And if you say at cold area, the terminology of cold area means is that that area of thyroid is deprived of functional thyroid tissue. So that means the normal thyroid tissue is being displaced by other pathologies, which we'll discuss later. Now, another key important thing when it comes to interpretation that is very important to note is that the position of the thyroid, like we know anatomically, that the thyroid is not sitting flat. The thyroid is slightly slanted anteriorly. And that is why, like we know from imaging procedure, any organ that is closer to the head of the camera will have more activity. And that's why, because the anterior surface of the thyroid is closer to the head of camera compared to the posterior aspect, it will appear more intense. So it will appear to you as if there's an increase in uptake, but this is indeed a normal variant. So this is one of the things that you need to take note of that. You can easily miss a hot nodule in this area, or you can call this a hot nodule. This is not a hot nodule. If you want to be clear about that, what you need to do is to do extra views. So apart from taking the anterior images, you can take your left right anterior oblique and left anterior oblique, just in order to display so that you can properly see that. You can see in this right anterior oblique that the anterior part of that thyroid, which is closer to the head of the camera, is portrayed. So one of the things that you need to do when you are evaluating your thyroid function test is, aside from looking at the uptake, you look at the parenchyma of the thyroid with the enlarged image and be able to assess that this uptake you are seeing, this hot area of uptake, is just a normal anatomical variant based on the position of the thyroid. The second important thing that you need to assess is also assess for the uptake in the parotid glands, because the parotid glands also take up and excrete technetium-99, the submandibular gland, and of course the outline of the patient. So in a normal thyroid scan, you will see the thyroid as the more intense uptake with the butterfly shape, but in addition, you will also see the salivary glands, you will see the background of the patient. In some disease condition, this is not visualized. That's why I'm taking some time to show you what a normal is from an abnormal. So a normal thyroid scan located in the front of the neck, it's butterfly shaped. It has an increased anterior part, which you would do an oblique in order to be able to be sure that you are not missing a lesion. Aside from that, you should see the salivary glands. You should see uptake within the mouth, because this is saliva. The technetium is excreted by the saliva. And of course, you will see the background of the patient. So this is what a normal thyroid scan look like. Now, apart from looking at the image, visually assessing the image, one of the beauty about nuclear medicine images is that we have the ability to quantify. I will not go into the detailed technology of how we do this quantification, but the idea of doing quantification is to calculate the percentage uptake of the radionuclide in the thyroid. And that helps you to know whether there is increased uptake, there is normal uptake, or there is decreased uptake, because different pathological process in the body or different diseases of the thyroid interferes with the uptake, the total uptake. So if you look at it, what we do is essentially with the images, we have a computer system that draw what we call the region of interest within the thyroid of the cell, within each of the lobe, and we take diameters. But in the end, we have these values. The most important value here is the total or the full thyroid uptake. You can see the full thyroid uptake in this patient is 2.4. And the normal uptake, percentage uptake of thyroid varies with the iodine requirement of the country or locations where the patient is. But normally it is between 0.7 to 4 or 1 to 4. So a normal level of percentage uptake of 1 to 4 is considered as normal. So of the injected 100% of the radiopharmaceutical, 2.4% has gone into the thyroid, which is normal. So if you have a level less than 0.7, is abnormal, is low uptake. If you have a level more than 4%, it is increased uptake. And I will show you why this is important. Other things that we can do in nuclear medicine, of course, also we can, based on this, we can also quantify the weight. You can see this weight of thyroid is about 27.8 grams. So this is a normal thyroid. Again, you can see how beautiful the thyroid is. You can see the increased area. And like I mentioned to you earlier on in my first discussion, that we can use any color preference. This color tends to accentuate the image better, but you can use the black and white that I've shown earlier on. It's all the same. It all depends on your color preference. And in subsequent slides, you will see where I use red, blue, and pink, depending on the preference, but everything is the same. So this is normal thyroid scan with the with the left lobe and the right lobe. The left lobe slightly bigger than the right lobe. You can see that there is uptake in both parotid and the submandibular gland. You can see uptake in the mouth of the patient because of saliva. But again, you can see that the patient background is there because you can make out for the head and you can make out for the chest region. And then the percentage uptake is about 2.4. Now, this percentage uptake is very important, particularly when we decide to use high dose radioiodine to treat patients with thyroid disease. Like example of patients that we treat with benign disease are Graves' disease, multinodular goiter, which is also termed the plumous disease, a single nodule, which can be hot nodule, cold nodule, or warm nodule. I'll discuss with you and show you images subsequently, thyroiditis, and congenital abnormality. Like I mentioned to you earlier, the importance of doing a thyroid scintigraphy is also one of the reasons is to calculate the thyroid percentage uptake. And the normal values that we use generally is between 0.7 to 4. Above 4 is hyper, means increased uptake. Below 0.7 is considered to be as low uptake. So essentially benign thyroid conditions that we utilizes thyroid scintigraphy with technetium-99m are those diseases: Graves' disease, multinodular goiter, single nodule, either hot, cold, or warm, thyroiditis, and congenital abnormality. So this is my first slide of a pathological process. Number one, you can see that this is a thyroid scan, but what is immediately seen is that there's intense uptake of radiopharmaceutical. You can see how intense and diffuse this thyroid gland is. It is diffuse that you cannot even assess the inner part or any part or the structure of the thyroid. So that tells you that the thyroid has taken up most of the activity. And you can see the background of the patient is reduced. The reason why this is reduced is essentially because the thyroid in Graves' disease is enlarged. There is hyperplasia and hypertrophy. So the thyroid is so hungry for radioiodine or pertechnetate. So whatever you inject goes into the thyroid gland. But you can see in this patient, despite this increase in uptake, you can see that the salivary gland are still visible. But in typical Graves' disease, what you see is an enlarged, diffusely increased uptake. And if you calculate the percentage uptake, look at the percentage uptake is 5.8. Remember, we said the percentage uptake is between 0.7 to 4. So this is about 5, which is high. So this is diagnostic. Usually this is the typical clinical feature that we see in patients with Graves' disease. The other disease that can give you a similar appearance is Hashimoto's disease. Remember, Hashimoto's disease has different causes. Hashimoto's at the early form can be toxic, and then they become normal. And then over time, because it's a chronic disease, there is infiltration of the thyroid by fibrous tissue and lymphocytes, and the patients become hypo. But oftentimes, this is the picture of Graves' disease that we see. We hardly in clinical practice ever get patients with Hashimoto's disease, because at the time when they are toxic, that undulant phase is usually very short, and they don't tend to have images before they get into the normal and abnormal. So if you want to describe this, you will say that this is a thyroid scan which shows an intense uptake with intense, diffuse, increased uptake of the radiopharmaceutical in the thyroid. You cannot see any hot or cold nodule. The background is reduced and the percentage uptake is also increased. So this feature is consistent with Graves' disease. Now, why this is important, again, looking at it, calculating this percentage uptake, is that these are suitable patients for treatment with high dose iodine. Because remember, we can use iodine 131 to treat patients with benign or malignant thyroid disease. And one of the things that we can do is, based on this quantification, this is a suitable patient, because if we administer high dose iodine, all the iodine will get into the thyroid and it will destroy the hyperplastic or the hypertrophied cells that are producing the excess of thyroid hormone in this patient. So this is another example. Again, you can see this is a typical thyroid patient, you can see that the thyroid again here is enlarged. There is absent background. You cannot even see the background of the patient because this patient's thyroid is so enlarged and the cells are so hypertrophied that they have taken up all the radiopharmaceuticals. And sometimes in Graves' disease patient, because of the inflammation and because of the hyperplasia of the thyroid cell, the pyramidal lobe also gets inflamed. So sometimes you can see uptake of the pyramidal lobe. And oftentimes whenever you see a diffuse thyroid uptake with an absence background and a presence of a pyramidal lobe, that is essentially what we see in patients with Graves' disease. So this is a typical patient with Graves' disease. Like I said earlier on, we give these patients radioiodine because we can calculate the percentage uptake. The radioiodine capsule is a very small capsule that is a single dose that is given to patient. I'm just going to flip through my next presentation just to show you one of the things that we do. So this is a patient with a typical Graves' disease. I have the permission of this patient to share her image. You can see there is an enlarged neck swelling. This is how her thyroid scan looks like. All right, so everything that we give has gone into the thyroid and you barely can make out a part of the patient. So this patient is a Graves' disease patient because you can see the enlargement of the neck and you can see the typical exophthalmia and periorbital edema that this patient has. So this patient are very good candidate for treatment with a low dose radioiodine. And this is the patient after just one dose of iodine 131 capsule and a low dose of about 20 millicurie was what we give. So with a single dose within 3 months, there is complete dissolving of the thyroid gland and you can see the patient looks very happy and joyful and she's happy. So with one dose of radioiodine, after you have done your thyroid scintigraphy, knowing the percentage in patients with Graves' disease, they benefit so well with radioactive iodine for therapy in this kind of patients. Now, the second kind of presentation that you can have is patient with multinodular goiter. Again, with multinodular goiter, this is the first image. You can see that you are seeing the outline of the patient. You can see the thyroid gland is enlarged, but you can see that one lobe, the left lobe, is bigger than the right lobe. And then you can see that it is not diffuse and homogeneous. And if you look at the pinhole, you will find that there's areas of increased uptake and areas of decreased uptake. So the gland is irregularly enlarged. There is not a diffuse uptake, but there is increased multinodular. So if this patient's thyroid function test is hyperthyroid, i.e. if the patient has symptoms of hyperthyroidism and the patient has an increased T3, T4 with suppression of TSH, then this is referred to as a toxic multinodular goiter. But if you see this kind of clinical picture in a patient who is euthyroid, that means that this patient's diagnosis is a non-toxic goiter. So your diagnosis of imaging depends on your clinical feature and depends on your thyroid function test. So this picture, if you look at it without the clinical history of the patient, all you can say is that this is a multinodular goiter. But if you have a clinical history of hyperthyroidism, then you can label this patient as a toxic multinodular. If the feature is a euthyroid picture, then this is a non-toxic multinodular gland. So again, important to note is that you can see that there are areas of increase and decrease uptake. This is typical of a multinodular goiter. Again, another example, some patients with multinodular goiter, the toxic nodules can have very increased uptake that you can barely see the outline, but it is not diffuse like what you see in patients with Graves' disease. In patients with Graves' disease, everything is uniform. There is no area of increase or decrease uptake, but here you can see there's one single nodule here, you can see another one. So you can see it's multinodular. Again, this is a multinodular goiter based on imaging. If the patient's clinical feature and laboratory profile is pointing towards hyperthyroidism, then this is a toxic multinodular goiter, also referred to as the Pulmus disease. But if the patient is euthyroid, then this is a non-toxic multinodular goiter. Now, again, it's important, like I said, the two terminologies that are very useful for us whenever we are evaluating patients with a thyroid abnormality is the cold and a hot lesion. Now, a cold lesion means that there is no uptake in that region of the thyroid. So if there is no uptake, means that whatever pathology that is there has displaced the normal follicular cell. So this area will appear as cold. Now, a hot lesion, in the other hand, is an area with increased uptake. That area shows increase, means that that area of follicular cells are hyperplastic and it's usually an adenoma. So it points to an increased uptake. So if you see an area that shows a hot area, it means that that area is rich or it's increased follicular activity. If it's absence uptake and it appears cold, it means that there is absent follicular tissue. And this is very important anytime we are evaluating our patients. Patients with a single toxic nodule usually will become benign pathology. If you do an FNA in this patient, the likelihood of malignancy in a patient with a single toxic nodule is less than 1%. But in a patient with a cold nodule, whenever you see a cold nodule, then you will have a lot of differential. It can be because of a thyroid cyst, it can be because of a hematoma, it can be because of calcification, and it can also be because of malignancy, because the thyroid malignant cells do not take off patecnitate, so they appear as cold. So any patient with a cold area, the first thing if you do like that, if you have an image this way, is to do an ultrasound. If it is cystic, no need to worry. If it is hematoma, you then realize. But if it is a solid single nodule that is cold on a thyroid scintigraphy, the likelihood of malignancy in this setting is about 15 to 20%. And therefore, biopsy or a fine needle aspiration is mandatory in this kind of patients. In this kind of patient, biopsy is not indicated because the likelihood of malignancy is less than 1%. Okay, so an example here of a thyroid scintigraphy of a patient with a neck swelling. You can see that this is the thyroid who shows normal uptake in the left lobe and in the right lobe, but then you can see that there is an increase round focal hot area. All right, so this is what you see in a patient with a single adenoma. Again, clinical picture is very important in this circumstance. If this patient's clinical future is towards hyperthyroidism and the laboratory test is showing features of hyperthyroidism, then your diagnosis here will be a single toxic nodule. If the patient is euthyroid, then this is just an adenoma. All right, so this is very important to distinguish. So whenever you're looking at the thyroid imaging, you will have a lot of differentials. But if you have your clinical future, clinical presentation, if you have your laboratory, particularly thyroid function test and a thyroid ultrasound, you can make a definitive diagnosis. So this patient has a neck swelling, had an ultrasound which shows a single solid nodule, and then the thyroid function test shows picture of hyperthyroidism, means that there is increased T3, T4, there is suppression of TSH. So this patient has a single toxic adenoma. Will you biopsy this patient? No, because the likelihood of malignancy in this setting is less than 1%. Another example of a thyroid, you can see this is a thyroid patient. You could see the part of the head, and then you can see the part of the neck. You can see that there is a single intense uptake. All right, and this patient had an ultrasound which shows a large solid nodule in the right lobe. And you can see there is increased uptake with suppression of the rest of the normal thyroid. And then if you look at the percentage uptake, is about 1.1. But in this circumstance, we do not use percentage uptake because everything has gone into the nodule. So this patient's diagnosis is an autonomous nodule. So an autonomous nodule is a nodule that is so intense, it's a toxic adenoma that it has taken up all the radiopharmaceutical and it has suppressed the normal thyroid, unlike what you have here in this patient with a single toxic adenoma. This patient with a single toxic autonomous adenoma, this rest of the thyroid is suppressed. Again, it is important to always interpret this thyroid image in line or in view of the patient thyroid ultrasound and thyroid function test. Another example of here you can see a red color. This is a suprasternal notch. Sometimes we use this to be able to see if there is a retrosternal extension or not. This is the neck of the patient, and this is the part of the shoulder. Here you can see an increase, a very large increased toxic nodule, all right, with suppression of the rest of the thyroid. So you cannot see the rest of the thyroid. Instead, what you are seeing is a very large toxic nodule. Again, this patient presented with a clinical feature of hyperthyroidism. The ultrasound shows this huge solid nodule, but you can then see that this nodule is hot. So this patient would not require biopsy because the chances or the likelihood of malignancy in this kind of patient is less than 1%. Another example worth of notice that we said earlier on is this patient. You can see this is the thyroid, again, the thyroid scintigraphy showing part of the head and part of the neck. You can see the beautiful left thyroid lobe. You can see the right thyroid lobe is enlarged, but within it there is a round cold area. So there's a single cold area. All right, if we magnify using the pinhole, you can see that it is well appreciated, that you can still see the cold area. The rest of the thyroid is normal, all right? You can still see it on all the views. Now, this is a single cold lesion. Without a history, without an ultrasound finding, you will give differential. So a single cold area can be a cyst, can be a hematoma, can be an abscess, and can be malignancy. So, but if you do your ultrasound will be able to exclude the three differential diagnoses. So if you have a solid nodule, for instance, in this kind of patient with a single cold lesion, the likelihood of malignancy in this patient is about 15 to 20%. And therefore, a fine needle biopsy is mandatory in this kind of patient. So if you have a patient with a single toxic nodule, or a single cold nodule, the likelihood of malignancy is increased. It's about 15 to 20%. But if there are multiple cold nodules, the likelihood of malignancy reduces with the number of nodules. So the more nodule you have, the more less cold nodule you have, the less likely is the chances of malignancy. So if you have a single cold nodule, then the chances of malignancy is high. Another example of a patient who had thyroid scan because the patient has an increased thyroid function. This patient was euthyroid, but thyroid ultrasound shows a large solid nodule in the upper part, in the upper pole of the left thyroid lobe. The thyroid scintigraphy here, you can see a normal right thyroid lobe. You can see the left lobe, but then you can also see a large cold area within the upper pole of the left thyroid lobe. In this patient, because there is a solid thyroid nodule, this is a single cold nodule. The likelihood of malignancy in this patient is about 15 to 20%, and these are patients who must have a thyroid biopsy to exclude malignancy. Okay, this slide is what I wanted to portray to you or demonstrate to you what the difference is between hot nodule and what happens, sometimes we refer to as cold nodule. Now, hot nodule, again, like we see in the previous one, you can see that there is increased uptake, it's intense, it's a hot nodule in the left thyroid lobe. And sometimes over time, these nodules undergo degenerative changes and they reduces in uptake and they become a little bit warm. So this is not completely cold because you can still see activity within the area. Again, the likelihood of malignancy in this setting is less than 1%. And these are patients who, if they are hyperthyroid, they can also benefit from therapy with radioactive iodine therapy. And that's the reason for doing a thyroid scintigraphy in a patient with a thyroid nodule, is particularly those patients in whom the TSH value is reduced. Good. This is another picture that we see. Again, this patient had a thyroid scan. This is a 30-year-old female who presented with severe features of hyperthyroidism. Hyperthyroidism, but look at that. We did a thyroid ultrasound. You can see that there is absent uptake. You cannot see the thyroid at all. Now, if you do not have a history, again, you can only give differential. Absence thyroid in this circumstance is, number one, it could be that this patient had had a thyroidectomy. Number two, it could be that this is an ectopic thyroid gland, or the patient would have had a contrast examination, because if any patient who had a high dose iodine, either a CT contrast, if you do a thyroid scan, you will not see the thyroid. Or this patient oftentimes will have features of subacute thyroiditis. Now, in subacute thyroiditis, if you do an ultrasound, this thyroid gland will be enlarged, it will be diffused. But if you do a thyroid scintigraphy, the thyroid gland will be absent. All right. Again, this is different from what you have in Graves' disease. And the patients with subacute thyroiditis and patients with Graves' disease present clinically the same. But we know that the therapy is different. Graves' disease patients would need antithyroid, would need radioactive iodine and subsequent treatment, whereas patients with subacute thyroiditis, because it's a viral infection, do not require any form of therapy because it's a self-limiting disease. And so thyroid scintigraphy is one of the things that you can use to differentiate between Graves' disease and subacute thyroiditis. The reason why the thyroid gland is not visualized in subacute thyroiditis is because there is acute inflammation of the follicular cells. The follicular cells became so acutely inflamed that they are unable to take up the radiopharmaceutical, and therefore that's why they're absent. If you calculate, you can see the percentage uptake is 0. So visually, you are not seeing the thyroid, and by quantification, you are also not be able to get any count from the thyroid gland. But this patient, because the thyroid ultrasound shows the presence of the thyroid gland in the presence of the neck, this patient did not have any contrast examination. This patient did not have any ectopic thyroid gland, but there's a presence of a thyroid gland on a typical feature of hyperthyroidism. This is what we see in subacute thyroiditis. Again, whenever you see an absent uptake or absent thyroid gland like this picture, you always remember the first diagnosis, particularly if the patient's thyroid scan or thyroid ultrasound shows a thyroid presence of a thyroid, is a subacute thyroiditis or recent iodine intake, or a thyroidectomy patient, or patients with thyroid agenesis or ectopia. So again, what I'm trying to emphasize here is that a thyroid scintigraphy is always important to interpret your thyroid scintigraphy in view of the patient's clinical history and availability of the thyroid ultrasound and the thyroid function test. One of the roles of nuclear medicine, again, is to monitor patients who have this kind of picture, who have a subacute thyroiditis, because what happens is that because it's a self-limiting disease, over time, the patient will start to recover. And over time, what you will see is that you will begin to see increase in uptake of the thyroid gland. This is the same patient, right? Now, this is 8 weeks after. We just did a thyroid scan 8 weeks after, and you can see that now the thyroid is recovering. So you can begin to see uptake. And when we did the calculation, there was 0.3. Still, there is a low uptake, but the thyroid gland is recovering from the acute inflammatory process. Another example of a same patient, this patient is a 30-year-old female who presented with a typical feature of hyperthyroidism, swelling of the neck with T3, T4 raised. Thyroid ultrasound shows a diffuse thyroid uptake, but we did a thyroid scintigraphy, which shows an absent thyroid. So you can see there is completely non-visualization of the thyroid, despite the fact that the ultrasound shows a thyroid. So in this kind of circumstance, we will say this patient has a subacute thyroiditis. Now, after 1 year, the patient came in to do an ultrasound, came in to do a thyroid scintigraphy, and you can see that this patient has recovered completely. There is a normal uptake in both thyroid gland, and her uptake is about 1.8. So thyroid scintigraphy can be used to distinguish between Graves' disease and subacute thyroiditis, and is a very important tool that you can use to monitor patients who have subacute thyroiditis. You look at the phase of their resolving and when they resolved their disease state. Now, in terms of congenital abnormality, one of the clinical indications for doing a thyroid scintigraphy with technetium is can be able to, particularly young pediatric patients who have features of hypothyroidism, we can look for sublingual thyroid or ectopic thyroid. The most common congenital abnormality is a sublingual thyroid, is thyroid agenesis. We see one or two of them. And another common and interesting one is a thyroglosal cyst. So this is a 6-month-old child who presents to the clinic with a hypothyroidism. So the thyroid ultrasound here showed the normal thyroid in this patient, but you can see the thyroid scintigraphy shows a complete absence of a thyroid gland. So in this patient, what has happened is that even though the thyroid gland anatomically is within the neck, but it is not functioning. And usually from the history, we found out that this patient has an organification abnormality. So there are enzyme deficiency with regards to organification of the thyroid. So even though that anatomically you are able to visualize the thyroid, it was looking normal in size, normal in shape, but functionally the thyroid is absent. All right, so this is a beautiful tool that you can use to monitor. Now, not only that this thyroid scintigraphy is able to make a diagnosis of a non-functioning thyroid, but it can also help if the patient is being on replacement therapy. Some of this patient, the follicular cells are able to recover, and you can use thyroid scintigraphy to monitor them to see for the possibility of recovery of some of the follicular cells. But oftentimes this patient will have to be on a long life thyroxine replacement. This is a thyroid scan of a child, again with hypothyroidism. This is part of the neck and the anterior region. Here you can see there's an increased uptake in the region of the neck, all right? Single increased uptake. In the thyroid bed, there is nothing. So this is what we see in a patient with a sublingual thyroid. So this is an ectopic thyroid gland, and it's usually sublingual. This is very important to make a diagnosis because these patients will need to be on replacement tyrosine therapy. Another thing that is also important to do is to also monitor this patient because they have a likelihood of developing thyroid malignancy in the future because of the ectopic location. So the most common congenital abnormality that you can be able to assess with a thyroid scintigraphy is a sublingual thyroid gland. Another example here again of an ectopic of a child with hypothyroidism. Again, you can see the normal thyroid is not within the thyroid bed. If you look at it on the lateral, you can see, but you can see two focal area of increased uptake in the region of the neck. Again, this signifies an ectopic thyroid tissue is an lingual, sublingual, and a lingual. So you can have two dual pathologies sometimes, a sublingual and a lingual. Again, it is important to monitor these patients because the likelihood of malignancy in future for them is there. Another usefulness of a thyroid scintigraphy in a child is, again, you can have unilateral agenesis of the thyroid gland. This is a 3-month-old child who presented with hypothyroidism. Now, thyroid ultrasound shows a beautiful left thyroid lobe, but there's an absent left thyroid lobe. All right, so we did a thyroid scintigraphy. You can see that there's an increase in uptake in the normal thyroid tissue that corresponds to that area of ultrasound. But then that area that the ultrasound didn't see thyroid tissue did not show area. So in this case, the ultrasound finding and the thyroid scintigraphy findings were the same. So this is a congenital absence of absence of one lobe of the thyroid, which is a rare condition usually. Now, another thing that we can see is something like this. You can get a patient with a huge neck swelling in front of the neck, and oftentimes these patients will come with an ultrasound. But interestingly, you can see that there is an increase. If you look at the thyroid scintigraphy, you can see that there is increased uptake. But apart from that, you can see that there is a long track of activity. All right. So whenever you see a track of activity like this, it signifies a thyroglossal cyst, because in a thyroglossal cyst, you expect that there will be no uptake in a normal cyst. A normal cyst will show as a cold area, but that is not the same with a thyroglossal cyst, because a thyroglossal cyst has some functional thyroid cells within the cyst, and therefore you can see that functional thyroid cells, and in addition, you can see the tracking. So this is a thyroglossal cyst. An example here again of a patient with a thyroid scan. You can see part of the neck. You can see that the two thyroid glands are seen, but they are small, especially the left thyroid lobe looks smaller compared to the right. But again, below the mandible, below the right side of the mandible, you can see an increased area of uptake. So this is an ectopic thyroid tissue. In addition to the normal thyroid gland, sometimes you can have ectopic thyroid tissues either within the neck or in the sublingual region. Now, so this discussion that I've had with you are mainly discussion looking at the indications and some of the pictures that you find for patients with benign thyroid disease. The next presentation will emphasize on the use of thyroid scintigraphy for the evaluation of patients with malignant thyroid disease. Now, malignant thyroid disease usually are divided into two. We have the differentiated thyroid cancers and the undifferentiated thyroid cancers. Now, the differentiated thyroid cancers are those cancers like papillary and follicular or mixed papillary follicular. They are differentiated because they still have the ability to concentrate iodine, and therefore you can use iodine for their treatment, and you can as well use iodine for follow-up of this patient. Now, when a patient is diagnosed with a thyroid cancer, the first line of therapy or the first line of management is to have a total thyroidectomy or a near total thyroidectomy. And the next line of therapy is to do a radioiodine ablation. And the idea of doing an ablation is to destroy the remnant thyroid tissue or the residual thyroid disease so that you can be able to use your thyroglobulin as a tumor marker to monitor this patient. Iodine, like I said earlier on, is given orally, and then we image the patient whole body. So anytime we are in imaging thyroid disease when it comes to malignancy, remember that what we use is iodine, either 123 or 131, and we give it as an oral, and we do whole body because we want to assess for the whole body for evidence of distant metastasis. So two important terms that are important for you to know is whenever patient has a post-thyroidectomy, patients with confirmed thyroid cancer and the patient has had a thyroidectomy, it is important for us to do an ablation. An ablation means that you give a high dose radioiodine to destroy the remnant thyroid tissue or the residual thyroid tissue. Now, two important terminologies that I used is remnant thyroid tissue. And a remnant thyroid tissue is just a normal thyroid tissue that remains after surgery. Sometimes after surgery, depending on how the patient is, the surgery, when there will still be some remnant thyroid tissue. And then you have a residual disease. And sometimes after surgery, any tissue that remains after surgery is termed as a residual disease. It is often difficult to distinguish between a remnant thyroid tissue and residual disease, but I'll show you subsequently in our images sometimes some of the telltale signs that can make you can help you in differentiating between remnant thyroid tissue and residual thyroid disease. But these are features that we look out for in patients who have had post-thyroidectomy ablation. So after ablation, the patient will have an imaging 48 to 72 hours after in order to look for these two disease entities, either remnant thyroid tissue or residual thyroid tissue. So again, the technique that we do is a whole body. We administer either iodine-131 orally for therapy, for diagnosis, or we can use the imaging that after high dose therapy, but because of the high dose that we give, we usually do the images 3 to 4 days later. The difference between the diagnostic iodine whole body and the therapy whole body is not very different. What you usually see in the post therapy is that the image resolution is usually poor, and you can see liver uptake, like I will show you in subsequent slides. So post-thyroidectomy ablation, follow-up suggestive of reoccurrence, increase in TG. Usually we do iodine for diagnostic, and after therapy for metastasis, we can also use iodine. So the clinical indication for doing I-131 is post-thyroidectomy ablation is to follow up patients for reoccurrence of their disease, and also for treatment after you have treated patients with, with malignancy. So this is 3 images of different patients just to tell you or to show you how the normal whole body iodine-131 looks like. This is a whole body iodine-131 post-therapy. All right, so post-therapy, this is what you will see. All right, you will see the outline of the patient. Remember that iodine-131 can be used both for diagnosis and therapy, but one of the problems or the drawback of iodine-131 is that the energy is not usually very suitable for imaging like patechnitate or iodine-131. So the image resolution is not as good, but you can make out for the patient head, you can make out for the chest, you can make out for the abdomen and the lower part. So the normal biodistribution is that you can see activity within the salivary gland or the mouth. You can see uptake in the gastrointestinal system because it is excreted by both gastrointestinal. You can see bladder activity. So if you see any other lesion outside of this normal biodistribution, this shows that there is an avid thyroid tissue, and this may be a residual thyroid disease if it is elsewhere in the body, or it may be a remnant thyroid tissue that is remaining after post-surgery. So again, it's important, but if you image what the normal biodistribution appearance depends on when you take the picture of the images or when you acquire the images. At the initial stage of the first 24 to 48 hours, you will only see the mouth area, you will see the gastrointestinal system excretion in the bowel, you will see bladder excretion. But later images, if you continue, maybe you do a 48 or 72 hours, as normal uptake, you can also see liver. So don't be surprised if you see a liver uptake in iodine-131. Remember that you are giving iodine, and iodine is eventually metabolized by the liver, so you will see liver uptake. So another second patient, this is a patient who had thyroidectomy, and then we did an image of iodine-131 following the uptake. Now you can see that there is a residual disease. Again, how you will differentiate residual disease is that usually it is large, it is outside not typical of the area of the neck. If you see an uptake within the thyroid bed, then that says that it's a remnant thyroid tissue. But if you see a large tissue within the neck area, not in the region of the thyroid, so that means that this is likely a residual disease. But again, what is important is that whether it is residual disease or whether it is remnant of thyroid tissue, the treatment is virtually the same. There is no really significant difference between how we do the treatment. Now, this is a patient with metastatic thyroid CA. He has received high dose radioiodine for his metastasis, and then we image them. Because we are giving high dose, we don't image them like we image this patient at 48 hours or 72 hours. We image them usually between 3 to 7 days. This patient was imaged at 5 days, and that's why you can see liver uptake. If you image this patient more than 5 days, you will also see liver, because again, iodine is metabolized by the liver. So what is important here is, apart, you can see the head, but you can see increased iodine avid tissue in front of the neck. You can see multiple uptake in the lungs. One of the problems here is that that we are looking at physiology, we are not looking at anatomy. So sometimes we struggle to find out where anatomy is. But again, if you do a SPECT CT, you will be able to have a three-dimensional image that will give you anatomical localization. But looking at the whole view of this patient, I will see that within the chest area, there are multiple lesions. All right, you can see this is the excretion in the liver, and then you can see excretion in the stomach, and you can see bladder excretion. So this is a patient with multiple metastases in the neck region, in the lung region, and again, this is showing you that there's residual disease plus lung metastasis. So aside from treating the patient, we can also use the scan to ascertain the uptake that we have, and it can also be a suitable technique to use to monitor and follow up patients. Now, this is a patient who had thyroid cancer. He had a total thyroidectomy. He had ablation with radioiodine 131, and whole body image is anterior and posterior projection. This was acquired after 48 hours. Because it is 48 hours, you can see that you see only the stomach and the urinary bladder, the liver, and everything is not there. But the region of the neck is absent. There is no iodine avid tissue. So at this level, we will say that this patient has received radioiodine. The ablation is significantly good, that this patient is in remission, and all we need to do is to follow up this patient with thyroglobulin. And anytime the thyroglobulin report comes out to be normal, we follow the patients. But if at any stage the thyroglobulin increase, it means that the patient is recurring. So we then can do another diagnostic scan in order to find out where the lesion is. So this is a normal whole body iodine 131 post therapy with radioiodine. I'll go into another example of a patient. Again, this patient had residual thyroid tissue in the neck. All right, you can see increased uptake in the neck, and then you can see lymph node. These are radioiodine avid tissue. But what this spike shows you is that this is a diagnostic high dose. So anytime you are evaluating iodine scan, you look for the avidity of the iodine. And each time you see this is called a septal penetration, this star phenomenon. Anytime you see a star phenomenon, it means that it was a high dose therapy. Another thing that will tell you that it's a high dose therapy is we image the patient late. Anytime you image the patient late, you will see the liver. All right, so this is a high dose radioiodine, post-radioiodine therapy to evaluate for the extent of disease. So you can see here in front of the neck and small lymph nodes, but the rest of the body did not show any abnormal uptake. Again, this patient will be followed subsequently with a thyroglobulin. Another terrible patient here, you can see again, patient received, you can see this is a high iodine, whole body iodine in anterior and posterior projection. Again, you can see this, the most intense iodine avid is in the front of the neck. Again, look at it, you can see that star phenomenon. Whenever you see those star phenomenon, it means that it is a high dose post therapy. And if you look at it carefully, you will see again that you can see some liver uptake. So this patient has an increased thyroid avid lesions, metastatic lesions in the front of the neck. There are also metastases in the lungs, in the liver, and then part of the liver. That's all. Again, this is another thing that you can see, and then this tells you that this patient has received a high dose, and all you need to do again in this kind of picture is to follow up the patients with a thyroglobulin. Another example is of a patient who had total thyroidectomy and received radioiodine. You can see an iodine avid tissue in front of the neck. But again, this is diagnostic dose or a low dose because we are not seeing the liver and we are not seeing that star phenomenon that we see because of septal uptake. So again, this is a series of patients. You can see increased uptake. This is a diagnostic scan. Diagnostic because one, you can see that you don't see that intense uptake to show the star phenomenon, and then you don't see significant liver uptake. That means that it was a low dose that was given and the patient was imaged within 24 to 48 hours. So this is as far as thyroid is concerned. So we have looked at imaging thyroid benign and malignant thyroid diseases. The next is I'm going to look at parathyroid imaging. So for parathyroid imaging, what we do is we use technetium-99m labeled with system-EB. And system-EB is the pharmaceutical agent that takes up this, that transport the iodine to the parathyroid. So system-EB is a chemical substance that localizes in areas that are rich in mitochondria. And that's why we also use system-EB for imaging patients for cardiac imaging, because the heart muscles are rich in mitochondria. So is an adenoma. So that's why we can use system EB to image patients with parathyroid adenoma. So the clinical, one of the single clinical indication for a parathyroid scintigraphy is in patients with hyperparathyroidism. But again, the first line of imaging modality of choice is a thyroid ultrasound. Again, because we know thyroid ultrasound is available, it's non-ionizing radiation and can be used as a first line of management. But oftentimes the thyroid scan will fail to distinguish between either whether this is a functioning adenoma or is a thyroid adenoma. And oftentimes if there's a high index of clinical suspicion, we can then do the MIBI scan, which I will show you subsequently. So we remember how the parathyroid gland is in relation to the thyroid. It is usually 4 glands. They are small, attached to the posterior lateral aspects of the thyroid. They can be ectopic parathyroid glands, again in the different locations. But then in patients with hyperparathyroidism, it's important to know the various causes. Adenoma accounts for 75% of patients, hyperplasia 10%, ectopia 5%, and malignancy in 1%. So nuclear medicine plays a very significant role in this group of patients because we can easily see an adenoma. Now, remember that whenever we are doing a parathyroid scintigraphy, we inject the system EB. But remember that the normal parathyroid gland is not seen in a nuclear medicine. So we do not see a normal parathyroid. Please, this is very important. Normal parathyroid gland is not visualized by the nuclear medicine CT or SPECT CT or PET CT. The reason is because the resolution of our camera is so small that we don't see it. So, but once there is an adenoma, and once there's an adenoma, what we do is we inject system EB. And system EB is taken up both by the thyroid and the parathyroid adenoma. But the physiologically is that the thyroid washes out this system EB. It clears it out over time. But adenoma continuously accumulated over time. So this is a process that we can use in order to identify adenoma because the adenoma will retain the radiopharmaceutical. This technique is called a differential washout technique. There's another technique where we can administer the 2 radiopharmaceuticals. We administer technetium, which is only taken up by the thyroid. We administer system EB, which is taken up both by the thyroid and by the parathyroid. And we then do a subtraction imaging in order to subtract for the parathyroid adenoma if it's present. So again, this is what we do. So if this is a patient with a high index of suspicion there's an increased parathyroid hormone, the patient did an ultrasound who shows a focal lesion in the lower pole of the left thyroid lobe. Now we injected system EB. So you can see at 1 hour, you can see both thyroids, but you can see an intense uptake in the inferior aspect of the left thyroid lobe. As you continue to image, you will see that the normal thyroid will wash out, but this adenoma will continue to increase, all right? At 4 hours, you can see that there's totally absent of the thyroid because the normal thyroid has washed out the radiopharmaceutical, but the adenoma will retain the radiopharmaceutical. So this technique is called differential. It's a single radiopharmaceutical that is used, but the process is a differential washout technique. Differential washout means that the differential washout of the normal thyroid, but then retention by the thyroid adenoma. All right, so images in this circumstance are done over time. First, when we inject, we do a 10 minutes image, we do a 2 hour or a 4 hours. Sometimes you can image up to 4 hours, but when you see a picture like this, you don't need to image up to 4 hours, you can stop at 2 hours because you can see that already the thyroid gland has completely washed out, but then there is retention of activity within the lower pole. So this area corresponds to an area of a functioning parathyroid adenoma. Again, remember in nuclear medicine, we are imaging function. So we are imaging functional parathyroid adenoma. Again, another example is that we can use the subtraction imaging. If you could see in this patient had patecnitate. This is patecnitate that is given. One thing I have to remind you is that whenever you are looking at a parathyroid scan, it is almost the same biodistribution with technetium, but the difference is that you will see cardiac activity, all right? Because remember, we are given system EB, and system EB is accumulated by areas rich in mitochondria. So you can see the parathyroid. Again, you can see, like it's pointed out, region of the mouth with the parotid and submandibular gland. You can see the lacrimal gland, which takes up the activity. Again, on the lateral aspect, you can see clearly the parotid glands because they are rich in mitochondria, so they take up the activity. The thyroid is also rich in mitochondria, but it washes out. The adenoma is super rich, especially functional adenoma, so it retains it more than that. So anytime you are reviewing an image like this, it's either a thyroid scintigraphy or a parathyroid scintigraphy. One of the ways in exams, particularly if you want to quickly know that this is a parathyroid scan, is you will see cardiac activity. So the subtraction imaging, like we say, you can see here that this is a thyroid with a patecnitate, and this is a thyroid scan, a scan that we did with a MIB scan. So we subtract the thyroid, and all that is remaining is the parathyroid. So the imaging of the parathyroid is very simple. It's usually not very difficult type of examination to do. What you do is to inject the radiopharmaceutical and image serially. Most departments, including my department, what we do is we do the differential washout, because we don't want to inject the patient with two different rates of radiopharmaceutical and adding extra dose to the patient. But please note that one of the pitfalls for a parathyroid scintigraphy, that the common false negative is the size. Again, like we said earlier on, the normal parathyroid gland is not visualized by nuclear medicine scan, and any adenoma that is less than 200 milligrams may be missed and may appear as normal. So one of the causes of false negative is a reduced size. And hyperplasia, the sensitivity of nuclear scan to diagnose parathyroid hyperplasia is low. So we don't oftentimes examine patients. So once we do a nuclear medicine technology and we see that we see a normal uptake and we don't see a parathyroid adenoma, our report will say that there is no evidence of a functioning parathyroid adenoma. But also put in mind as a caveat that any parathyroid adenoma that is less than 200 milligrams can easily be missed, and we can miss patients with hyperplasia. So our important role is to diagnose patients with a functioning parathyroid adenoma. Another thing that is worth mentioning is the cause of a false positive. One of the common cause of a false positive is when you have a thyroid adenoma, especially when you have a toxic adenoma. All right, the toxic adenoma will also behave similarly to how a parathyroid adenoma behaves. It may have the same uptake, it may retain it like the parathyroid gland retains it. So one of the ways you can, one of the things that happens in this kind of patients is that you can miss it. So another, if you have a situation like this, an ultrasound will be helpful, or a biopsy may be used to exclude the possibility of an adenoma. So again, another example, like we said, this is a patient with a clinical feature suggestive of hyperparathyroidism. Ultrasound shows a nodule within the inferior pole of the left thyroid. You can see the nodule. One will not say this is a thyroid adenoma or a parathyroid adenoma. We injected the patient with systemibi. How we know that this is systemibi is because we can see cardiac activity, we can see liver activity. Technetium patecnitate does not go into the liver, and it's not taken up by the cardiac. So once you see those things, these two organs, it means that it is technetium systemibi that is injected. So at the initial injection, you can see both thyroid, but you can see a focal uptake that corresponds to this area that we see on ultrasound. But over time, you can see that the thyroid is washing out, the thyroid had completely washed out. So by 2 hours, the normal thyroid has washed out the radiopharmaceutical, but the remaining focal uptake has retained it. And this is typically of what we see in patients with a functioning parathyroid adenoma. Another example here is a patient with an increased parathyroid hormone and evidence of hyperparathyroidism. Ultrasound scan was completely normal, and there was no any evidence of nodule on ultrasound. But then we did a parathyroid scan. Again, how to know that this is a parathyroid? You can see cardiac activity. So that means that what we inject is technetium with systemibi. You can see part of the liver uptake. So you can see the normal uptake in the salivary gland. You can see both thyroids showing normal uptake, but then you can see a focal increase uptake in the region of the chest wall. All right. Over time, the normal thyroid has washed out. All right. But then there is retention in this organ. So here we will say that there is a functioning parathyroid tissue, a functioning parathyroid, ectopic parathyroid adenoma. And then we need a CT, SPECT CT here to exactly know the anatomical localization of this lesion. So in summary, I have been able to give you an overview of imaging of the thyroid disease. We looked at the imaging benign versus malignancy. In benign disease, we use patecnitate, and essentially why we use patecnitate is because we just want to make a diagnosis. We want to see the thyroid physiology and metabolism. We want to look at thyroid uptake. In malignancies, particularly thyroid cancers, we use iodine 123 or 131, and we use it for post-ablation for follow-up. We can also use it to monitor patients with metastasis. So at this point, I would like to share some images. I have a few images that I would like to share. So first case.
Okay, thank you. It's amazing, really, Dr. Jawa. And we are very thankful for you. Doctor, I will ask any candidate here who want to take hot seats. Can you raise hand? And we will start.
Okay, so please, before we go into the sessions, the quiz session or the review session, what is important for thyroid scintigraphy is that the history will always be there. The key important history, please look at it. Okay. But one of the important things is that I want you to identify the study. I want you to make an effort to describe what you see and to come up with a diagnosis. And then if you come up with a diagnosis, what recommendation will you give? So 4 important things. Identify the study, describe the pathology that you see, prefer differential diagnosis, and then recommendation is available. Okay. So first case.
Okay,
so the first case is a 55-year-old.
Dr. Isam Hashim, اتفضل. Dr. Isam, you are with Dr. Jawa.
Hello, thank you very much, Dr. Jawa.
Okay, Dr. Isam, this is a 55-year-old lady with a left neck nodule. The ultrasound shows a solid mixed echogenic mass.
Okay, so these are 3 images of thyroid scintigraphy using technetium perticlitate, frontal and 2 obliques, showing a large area of low uptake, almost cold area in the in the left upper thyroid pole. I do not see background activity, maybe because of the using pinhole collimator. Otherwise, no high or low areas of uptake. The thyroid size looks normal, no other abnormality detected. My differential diagnosis for this case, given the ultrasound picture, is a hematoma versus a tumor. I think the other ultrasound features are important, like lymph nodes and Doppler vascularity, and an ultrasound guided biopsy would be indicated.
So very good. This is very good. So for me, this is absolutely wonderful. You have identified the technique. You have beautifully described the pathology, and you have preferred solution. So what is the likelihood of malignancy in this setting? If it's a cold nodule,
it's yes, as you said, it's about 20%. Yeah, maybe more because it's not assist. So
thank you very much, Isam. This is wonderful. So this is absolutely wonderful. Case number 2.
Thank you.
Okay, any other candidate can raise hand? Dr. Sharif Sobki, Dr. Awala, the famous candidates sharing with us. Dr. Anyone is available? Dr. Muhammad Yusuf, you can.
Okay, so Dr. Muhammad Yusuf, this is a 33-year-old female with a sign and biochemical profile of hyperthyroidism. And she has this hyperthyroidism for 6 months. Her thyroid ultrasound shows a diffused, increased thyroid. And she had a scan.
Okay, this is a thyroid scan with technetium perticlitate. It shows an intense diffuse uptake of the thyroid gland, which is also enlarged with a total uptake of 37% or 38%. Features are diagnostic of Graves' disease.
Thank you very much. So what will be your recommendation for this patient? Is this patient suitable?
I would recommend iodine.
Therapy. Exactly. Yes, so beautiful. This is beautiful. So this is a thyroid scan. It is showing diffuse increased uptake in the thyroid. Percentage uptake is extremely high. So this is a suitable candidate for therapy with radioactive iodine. Beautiful. Thank you very much, Mohammed. Okay, next patient.
Okay.
Next case.
Any other candidates can raise hand or here. Anyone is volunteer to accept the case? Okay. Again, Dr. Isam Hashim, if you are available to take the case, no problem.
Okay.
Dr. Amr, yes, Dr. Amr.
Dr. Amr, this is a 53-year-old lady with toxic symptoms. Toxic symptoms.
Yes.
She has symptoms typical of hyperthyroidism, and she has a low TSH and a neck swelling. So she did a scintigraphy.
Here I see three selected images of technetium per technetate, showing asymmetric uptake with a bilateral enlargement of both thyroid loops with areas of increased uptake more than other areas. Here in a frontal and both lateral views. My differential diagnosis will be toxic multinodular goiter.
Good, beautiful. So what will be your recommendation for this patient? In a patient with a toxic multinodular goiter. Beautiful.
Yeah, my recommendations will be assess TSH and refer to surgeon for that.
Okay, so again, you are correct, but this patient will do well with radioactive iodine therapy. The likelihood of malignancy in patients with multinodular goiter is about 5%. So some clinicians will do a biopsy. I am one of those people who will do a biopsy to exclude malignancy, especially in the cold lesion, because you could see there are multiple areas of hot, warm, and cold. So it's a mixture. All right, so I will, based on with ultrasound guide, just exclude malignancy. So this patient is a candidate for radioiodine or candidate for surgery, depending on so many things, all right, clinically. But this is beautiful. Thank you very much.
Thank you.
Okay, next patient. Next
Okay,
case.
Dr. Sharif Subki, are you with us to take this case? Yes, Dr. Sharif.
Okay, Dr. Sharif, this is a 43-year-old male with a neck swelling. His thyroid function tests are normal.
Okay, so technetium 99 scan of the thyroid, an oblique view is shown. There is a cold area, focal solitary cold area in the left thyroid lobe. The clinical information that we're given that it is normal thyroid function tests. I would correlate with any ultrasound findings to see if this lesion is characterized, and the differentials can include the assist malignancy or hematoma, but an ultrasound will be essential to help narrow down the diagnosis.
Beautiful. So if your ultrasound shows you features suggestive of a single nodule, increased vascularity, there are lymph node on the ipsilateral side, what will be your likelihood of malignancy?
So it will make malignancy more likely in this appearance, and then I would recommend FNA as an essential next step in management.
Beautiful. Thank you very much. This is absolutely wonderful. Good. So
Okay,
next
Dr.
case.
Wala or Dr. Layla Mohsin, female candidates, if anyone are available. Dr. Wala or Dr. Layla. I think we can repeat the Dr. Asam can, Dr. Asam can, Dr. Sayed Am. Okay. Okay, we'll give everyone the chance.
Okay. So Dr. Sayed, 43-year-old male with a neck swelling and a low TSH.
So I presented by one image of thyroid scintigraphy with 47 years old mean swelling. I see there is increased activity in the right lower lobe, right thyroid lower lobe with dense uptake of radiotracer. So this is hot spot in the case of uptake. So this is toxic nodule.
Beautiful.
Toxic nodule goiter.
So what is the likelihood of a malignancy in a single toxic nodule?
It is less than 1%.
Beautiful. So biopsy here is not so recommended. Okay, good.
Not a
Thank
compromise.
you. Thank you very much. Okay, so this is a similar one to what we have seen here. The only difference with this image is that this one is an autonomous. All right, because there's a single toxic nodule suppression. Okay. Okay. Next is.
Okay, we'll gain Dr. Isam. Start again with Dr. Isam. Dr. Wala, I think Dr. Wala is here. Okay, wait to give everyone new chance. Dr. Wala, you can take the case. Dr. Wala. Hello, Dr. Wala.
Yes. Hello, assalamu alaikum.
Okay. Can your voice is away?
Hello.
Okay, Dr.
Yes. Assalamu alaikum.
Okay. Alaikum salam.
ايوه حضرتك سامعني يا دكتور كده دلوقتي سامعني؟
Yes, we hear you. Okay, Dr. Jawa.
Yes. So this case is a 67 lady with a thyroid nodule, and she had iodinated contrast CT 5 days ago.
There is two images of thyroid scintigraphy using technetium technitate showing no evidence of thyroid uptake of tracer. No abnormal area of uptake seen in the neck or upper chest. So diagnosis could be thyroidectomy, total thyroidectomy, versus no evidence of ectopic thyroid nodule. I would correlate the finding by clinical data, and I'd like to do ultrasound to assess thyroid tissue and assess thyroid function.
Okay, good. So remember, this history is that this patient has a thyroid nodule. So it means that this patient didn't have any surgical procedure, right? But what is key here is that this patient has contrast examination. And contrast examination is one of the differentials that shows an absent uptake, okay? So her absence of uptake is not because of any disease, it is purely technical issue. So in this circumstance, we will not be able to report this kind of scan. We will not be able to report this kind of scan. We will tell the patient to return in 3 to 4 months' time, because the iodinated contrast medium is interfering with the uptake of the gland, all right? So anytime you see an absent uptake, is either the patient has a subacute thyroiditis, or an absent thyroidectomy, or a patient has had iodinated contrast medium, all right, or an ectopic thyroid, okay?
Okay, thank you, doctor.
Thank you.
Okay, Dr. Amir Nabawi. Dr. Amir Nabawi, can you raise your hand if you are available? Dr. Amir Nabawi. Okay, we'll repeat the same candidates. Okay. Dr. Said. Dr. Isam.
9 months old female child with hypothyroidism.
Dr. Isam.
Okay, so this is a technetium technitate scintigraphy for showing absence of the normal butterfly shape of the thyroid, but there is a small active nodule in the midline, probably related to the base of the tongue. My primary diagnosis would be lingual thyroid.
Thank you very much, Exam. Good. Okay, so now we will go to the cancer. This is a patient with a papillary thyroid cancer. The patient had post-thyroidectomy and then had ablation with radioiodine, and then she had a scan for 24 hours after. So this is whole, yeah. Anyone?
Dr. Said, okay, yeah, Dr. Said.
Okay, so I present here by this thyroid total body scan of thyroid 131 for both thyroidectomy for post thyroid cancer to rule out if there is residual uptakes in the region of the thyroid gland. So there is a dense uptake in the midline in the region of the thyroid gland, in the center of the thyroid gland here. For this, indicating there is maybe there is a remnant of the cancer here.
Beautiful. So this is either a remnant disease or a residual thyroid. It's a residual thyroid tissue, a residual disease or a remnant thyroid tissue, right?
I think this is remnant of residual from the cancer.
This is residual. Thank you very much. Because of the location, okay, this more looks like more
abnormal location.
Because the patient had a total thyroidectomy, okay?
Yes, okay.
Okay, thank you very much. Next case.
Okay, Dr. Sharif Sobki or Dr. Muhammad Yusuf are repeating the list. Anyone available? Dr. Sharif, can you raise your hand, please? Yes, Dr. Sharif. Yeah. Yes, Dr. Sharif.
Okay, this is a technetium iodine 131 scan for post-thyroidectomy for a patient who had papillary thyroid cancer.
Right.
I can see normal uptake in the mouth, parotid gland, submandibular glands, and I can see normal uptake in the stomach, and there is some contrast in the bladder as well.
Okay. We don't say contrast, the excretion of the
radiation in the bladder.
Right.
There doesn't seem to be any uptake in the thyroid region, so there doesn't appear to be any evidence of residual disease.
Thyroid. In this case, you would say this patient is on a follow-up. So this patient, there is no evidence of an iodine-avid disease to indicate reoccurrence of disease. So this patient is in remission. All right.
Yeah.
Beautiful. Beautiful. Beautiful.
Thank you.
Okay. Now this is the last one.
Okay, Dr. Amr, I think Dr. Amr Awad is ready. Yes, Dr. Amr.
Hello, again, thank you for the amazing lecture. A patient with thyroid cancer,
right.
with thyroid scintigraphy, no high dose therapy, iodine 131,
right.
it's showing increased uptake in the central area within the lower neck, okay, which indicating the iodine dose therapy, as well as numerous metastatic uptakes in chest bilaterally.
Right.
And also I can appreciate some uptake in abdomen also.
Beautiful. Thank you very much. Okay, beautiful. I am extremely happy. So in summary, today we have looked at thyroid and parathyroid scintigraphy. But remember that scintigraphy of these two organs means that we are looking at function. In thyroid, we are looking at the metabolism of thyroid hormone. And it is worth, I like to emphasize that thyroid scintigraphy will be absolutely meaningless if you do not have a clinical history, ultrasound, and biochemical profile. Remember that your ultrasound is your first imaging of choice. The best way to evaluate a thyroid disease is a one-stop shop. It's a combination of your clinical history, your thyroid function test, your ultrasound, and your scintigraphy. But I will always say that even though scintigraphy is complementary, there are situations where it significantly aids in the diagnosis of patients, particularly in patients with hyperthyroidism, to differentiate between the various forms of hyperthyroidism. It can guide biopsy and therapy because we use high-dose iodine for benign or malignant thyroid disease. And thyroid scintigraphy is also with iodine 131 a very useful technique for the follow-up of patients with thyroid cancer. I'd like to thank you all, and you are all wonderful audience. Thank you very much.
Thank you, Dr. Jawa, for this amazing lecture. And also, I want to make everyone happy by saying that Dr. Jawa promised us to continue these lectures to cover all important topics of nuclear medicine. Also, he promised us he will review the recorded lectures, and inshallah will be available for you inshallah as soon as possible. So thank you again, Dr. Jawa, and we hope to meet you again inshallah soon. Thank you for very much.
Thank you very much, everyone. Thank you.
Thank you. See you soon inshallah.
Inshallah.